Hello everyone, I hope you're doing well. My name is Bhagyashri and I would be the host for today's exciting event. I would firstly like to thank you for taking the time out to attend the interactive learning power hour session hosted by Harbinger. For those of you who are joining us for the first time, Power Hour is a series of interactive roundtable discussions amongst industry stalwarts where they would be sharing their experiences and insights on a particular topic. So, the topic for today's discussion would be how to create an effective telehealth roadmap. Prashant, if you can go to the next. Before we begin, here are a few housekeeping tips. In case you cannot hear the audio, ensure you are selected the right speaker for audio output. You may test the same to see if it is working fine from the audio settings option from the lower left corner of your screen. If necessary, dial in using the phone. With that, now it's a time for the introduction. Our host for today's roundtable is Prashant Khambekar. Prashant has 20 plus years of rich experience in engineering, management, and business development of software products. He is the head of health tech line of business at Harbinger. His deep involvement in customers' products in provider, payer, pharmacy, and clinical trial segments has worked wonders for the customers. Prashant enjoys writing and putting forth his thoughts on the evolving healthcare landscape. Blockchain, IoT, and data engineering are Prashant's area of interest and passion, where he is known to be leader of new initiatives. Welcome, Prashant.
Thank you. Thank you for the nice words, Bhagyashri.
Yeah. At the end of this power hour, we will be able to understand the telehealth and its potential in the near future, know the numerous possibilities when utilizing technology for telehealth, and know the criteria of getting the best possible telehealth product for your customers. With that, Prashant, we welcome you for this hosting of this exciting event, and over to you, please.
Thank you so much. So welcome everyone. Telehealth is a vast field, and we are fortunate today to be joined by two eminent people. We have Dean Hudson with us. I'll do just some brief introductions and then hand over to them to add a few words of their own. So we have Dean with us. Dean is the CEO and co-founder of Curaguard, which is into telehealth. And in addition, Dean wears multiple hats. So he wears a hat in the private healthcare enterprise space. So he's, he is associated with St. John's Regional Medical Lab, as well as Tulsa Health. And in addition to the kind of private enterprise, he's also helped the government and the authorities with laying down healthcare plans and initiatives. We are also joined by Elisha. Elisha Yaghmai is a physician. He's based in Wichita, Kansas, and he's a practicing physician. So, just a few minutes back, he was working with patients. And his specialties include internal medicine, family medicine, pediatrics. So he does that. And in addition, he has the platform called FreeState Healthcare. And that aims to bring telehealth to vast number of people. So we are joined by these people. So in some random order, I would say, Dean, can you go ahead and see if I missed out anything and you want to add a couple of words from your side?
You bet, and thank you, everyone. It's a pleasure to be here. Yes, I'm the CEO and co-founder of Curaguard. We are a digital health platform, which not only includes the capabilities around engaging in telehealth, but also remote patient monitoring. Our focus is really extending that engagement of care beyond the traditional care models to reach patients. I have a vast background in healthcare, been in part of different avenues in healthcare related to from different strategy models, care models, and business intelligence as well. So pleasure to be here today.
Thank you. Elisha, you are on mute, so can you please unmute
Yeah,
yourself?
sure. Yep. Hi, everyone. Yeah, so my name is Elisha Yaghmai. I'm an internal medicine pediatrics physician and also part of FreeState Healthcare. We started several years ago delivering care virtually to a variety of small, underserved, and rural communities throughout our state of Kansas using telemedicine technology. We've been doing this at this point for quite a while and therefore have gained some experience in how to deliver care over a wide area using these kinds of modalities. And I'm also very honored to be here today.
Thank you. So I'll talk a little bit about telehealth before we ask questions to our panelists. So telehealth is getting to be like a kind of like a multi-varied field. I'll kind of just talk a little bit about what I see as some of the different segments within telehealth, and some of the companies, these are by no means all the companies, but some of the companies that are doing certain things in healthcare. So we'll come to Teledoc and Sherpa later, but if we talk about specifically about remote patient monitoring, then we have companies that in some sense are like device heavy or device led. So there is Medtronic, there is Welch Allen, who have their devices. And then there is, a company in baby and like neonatal kind of space, which is Nanit. So these are some companies in that space. Then in terms of like what might be considered as mobile delivery of health or mobile heavy, there is Headspace, which is into mental health or meditation and that kind of thing. And there is a company, also a different company called Ada. Then video consultations, that's kind of like key, where the patient and the doctor are separated. And some companies essentially focus on kind of like bringing the doctor and the patient together over the video consultations. So a couple of companies in that space are iClinic and MD Live. Then what I consider as like one of the great benefits of telehealth now is that not only can patients talk with their doctors, but doctors can talk with other doctors also in a remote fashion. And so whereas I don't know if there are any special products that are out there and we can learn from our panelists, but basically, the ability that a doctor can get assistance from other specialists and so on, who may be remote, and they can like view charts, they can view videos, they can view CT scans and so on, and help diagnose or recommend something to for the patient. So that's important. Then kind of like at a somewhat like a lower and kind of like a lower granularity, there are some companies that are into smaller areas. So Pager and Heal are companies that essentially enable on-demand house visits. So you need somebody, you like make a request, and then somebody will make a house visit. So it's not exactly telehealth, but it kind of helps it helps the patient with their problem. Then there have been alarm companies for a long time. So Great Call and Medical Guardian are a couple of them, where especially if like senior citizens or people who have disabilities need help, then they can like punch a button and it automatically generates an alarm where either the 911 network or their private nurses and physicians can call on them, or it can also inform their personal caregivers, like their relatives who are looking at them. Then specifically with regards to pharmacy can be delivered now, medication can be delivered, but PillPack is one of the like early companies in that area. where the medicines will come to your door. And it is not just about the medicines coming, but it is about the organization of the medicines. So it's like, okay, somebody needs to take something in the morning, something else in the evening, maybe a third thing in the late evening. The organization of that, and like creating like a weekly or a monthly intake of the medicines. So PillPack handles that. Then there are companies that track whether, especially the pills or the medications are done properly, and the adherence, because if there are costly medicines and costly treatments and the companies don't really adhere, the patients don't adhere to the regimen of the medicine, then the effectiveness of the treatment is reduced. So there are companies like Medisafe and AdhereTech in that space. Then there are some companies like Patient Fusion, which just help you find a doctor. So even like finding a doctor, where is the doctor close by me to where I am? What if I am on vacation and I still need a doctor? Like, how do I get to it, and so on. So there are companies that help you find a doctor close by. So after that, it is an in-person visit, but at least it gets you over that initial hump of that. And then there are, of course, the fitness, that is very important. And so companies like Fitbit and Care Clinic are into that. And then Teladoc is a company that does kind of like very comprehensively. It's a huge company. It's roughly $40 billion. So that kind of indicates that there is potential for telehealth to be like extremely large. And then now other players are also coming in. Amazon is coming in, Google is coming in. So these players are also coming in. But enough about me talking about what the landscape is. I would say, Elisha, can you talk a little bit about FreeState and what does the product achieve?
Sure, I'm happy to. Basically what we did over time was we started out trying to solve the basic problem of places that did not have access to care. So these are small or remote communities, rural communities that historically have always struggled to recruit any kind of care provider, much less a physician specifically. And the problem was that they either couldn't get anyone or they were paying enormous prices to get people to come out. The quality of what they got was often variable. It could be very good, it could also be terrible. And there really was no alternative to that system. So our proposal was simply to use virtual technology to distribute physicians to multiple small locations at the same time. Over time, that just organically built out to, we started off talking about, internal medicine or family medicine, these kinds of specialties, but it built out into all the different types of medical specialties. So rheumatology, neurology, you name it. All of these things were needed in these communities. And just as part of that, when we started, it was early enough that the technology that was available at that time was extremely expensive and very difficult to use. So, not being too ignorant to know what you're not supposed to be able to do, we, got into the process of actually trying to design some software to meet our clinical needs, because the products on the market at that time did not meet our needs. And the same actually goes with kind of a hardware profile. We ended up putting these things together. So what we've seen, and the interesting thing actually, Prashant, about all of these companies, is that right now the approach to this care has largely been fragmented. There's a different vendor for each sort of subsection of things. But our experience has shown that frequently what people want and benefit the most from really is an integrated service that is able to do a variety of these things all within one place, rather than one thing or another. And that's something that we are still in the steady process of trying to build toward. But I think that realization is dawning on people. So frequently when when a healthcare system, for example, wades in, they're immediately much more potent because they have all these different arms, right? That can deliver different types of things to patients, as opposed to the app for this and an app for that, an app for this thing over here and an app for that. So one of the dangers that we see with this is that you can end up with a very, very even more fragmented system than our already, at least speaking for the United States, incredibly fragmented system as it is. But the flip side of that also is that it's now possible, as you already alluded to deliver all of these services to somebody in one place. And that has tremendous value to them, not just in the usual kind of businessy financial sense, but for their life. It has tremendous value to be able to do all these things in one place very conveniently and easily, no matter where the location is. So we do see a lot of positives about the development, and I would say just our personal experience has really mirrored this in terms of we start in one place, and then patients will say, well, could you also do this thing, and we figure out how to do that, and then how do I get my medication, so we figure something out to do that. And it's just been that process of growth and evolution in response to organic requests that we're getting.
Fantastic. Yes, and we'll talk a little bit about more in detail about the whole thing in the subsequent discussion. Dean, can you tell us about Curaguard? What does it do and how does it work?
You bet. And I, definitely mirror a lot of things that Elijah experienced. We deal with that in the industry since we started in 2016. There was a lot of fragmentation, and there still is, especially in the US market, because it's also looking at how reimbursement is modeled, what we have to do. So there's a lot of different organization types. There's a lot of niche players that will actually kind of be very focused in one area that can deliver almost the application delivery that they say they can, but then they have the challenges around meeting the other things from a holistic view, like Elijah said. And that is why we approach as a digital care platform, to where we can take those different pieces of telehealth, remote monitoring, extending care beyond different care models, as well as being able to, from a extended, growth in the chronic care world, the aging population. We have avenues now that we have from a capability to extend care to those people who may not be, quote, technically, enabled. We have caretaker solutions and things that will help reach those markets, those rural areas, as well as those markets of the segment that are really challenged by technology. So we were able to extend that information. So we look at everything, as Elijah mentioned, from a holistic view on being able to get the full view of the patient. It doesn't matter if this is a telehealth visit, but it also could be somebody's using a remote monitoring device that may be a clinical device, but also maybe even a Fitbit and maybe something else. Well, our platform looks at bringing all of those things together to where you get to see the whole patient. The physician gets to look at the care information on that patient, regardless if it's just a normal monitoring situation, a telehealth visit, or even a transition of care, engagement. So we look at that from all aspects, and that is our platform description and kind of where we look at the outcome-based view of that patient, that engagement with the physician, the most efficient care around that model, and that's kind of who we are.
Got it. Okay, let's take a little kind of like a pause and bring the audience in, and we would like the audience to answer a poll. We'll talk about how things start and what goes into a roadmap and so on. But what does the audience think is important in terms of like getting the solution and product going? So not the decision about what the roadmap should be, but once the roadmap has been decided. And so this will just help us, understand the audience a bit better. So Bhagyashree, can you put up the poll, please? All right.
Yes.
I know it's a little bit like you have to think a little bit because the healthcare segment is complicated, and telehealth is like just burgeoning. So,
right.
Yeah.
All right. We'll give a
Okay,
couple
you
of
want to
more
give like a couple
seconds.
more seconds to people to make their
Yes.
choices?
Yes. All right. So
All right, some people are still responding, so give them a couple of more seconds, please. So I can see the poll like getting filled up. Okay, I think we can.
Okay, so in next 5 seconds, I'll end the poll. 5, 4, 3, 2, 1. And I'm sharing the result.
All right, so I think the first one got the largest amount of votes, making the solution work seamlessly with the physicians involved. And then the second one was like going to the market and convincing that the solution has value. And then we have like strict healthcare regulations as being significant, as well as the rapid changes in technology are significant. And at the very like lowest priority seems to be limited development resources. So that's good to know, right? Okay, so that was good. Have you stopped sharing, Bhagyashree? All right, so now to Dean and Elisha. So Dean, can you indicate, like, you said that you started many years ago. So how did things start? I mean, was it like just one day you woke up with the idea and you had like this whole clarity about the solution, or did you talk with a lot of people? What was the initial process?
The actual founder, I'm a co-founder. The actual founder had a engagement with a personal, acquaintance who had a clinical issue that, let's just say, did not end well. And that drove him to figure out a better way to look at how someone is engaged with, the physician, how care is monitored, how the gaps in care were occurring, how they missed a lot of that engagement with the patient. So it really drove the thought process as to really kind of stepping back and thinking about, okay, who are the influencers in healthcare? Who are the engagers? Who are the, the people or the participants? Really looking at and really modeling out how that care from a traditional model fails, exceeds, is actually, outstanding. Where were those gaps, and where could we actually design a solution to come in and actually encourage engagement, improve that, that model, but also actually focus on the outcomes and be able to monitor that with evidence-based information to actually give that feedback and show the value. That's in a nutshell. Now, don't get me wrong, there was tons of processes behind that, a lot of questions, a lot of iterations, but that was the initial thought process with our founder, and then the initial subsequent co-founders. We have some outstanding folks involved in our platform and our care engagement that actually drove a lot of this.
And was the your co-founder the one with the problem with the the initial episode? Did that person have a background in healthcare, or
no?
was it just
they did not. They did not. They were a kind of a consultant, technology consultant that had various background in business intelligence and other industries. But was able to, kind of get the thought process together and then pull the team in and start asking questions. I was able to join and be a part of Curaguard as the co-founder and actually help drive that platform along with some other really key members of our team.
And was it was it initially very chaotic, or because of your background in healthcare, you kind of brought a semblance of order and
Yeah, I
thinking
was
through.
able to. Yeah, I was able to actually kind of bring that information, from a different, I guess, perspective on being involved in care, being involved in outcomes, being involved in the data side of it, and being able to look at, what an outcome model looked like, what is really involved in value-based care, what is in care engagement, working with some very good physicians, working with some very good people with some true insight on the challenges of healthcare from the traditional model. So that we used a lot of that information to bring that in. We have some very good healthcare focused people on the team that surrounded the initial founder that actually helped launch this. And certainly it was, people beyond my scope as well that were able to really bring this information together. So it is a true team effort for our group.
Great. Elisha, same questions, like how did you start who were the other people involved? Was it like a very sudden kind of realization for you, or how did it go?
Yeah, no, it was, in my case, it started as a reaction to the U.S. healthcare system. So I was working as a physician in a tertiary referral center for the Northwest region. And after doing that for some years, I did not like what we were doing in that job. That's probably the best way to describe it. So I was just on a personal level looking for something to do that I felt would offer more value. Again, not monetary value, but just would be some useful contribution to the world, as opposed to fighting with insurance companies. So, which is ironic given what we did next. So the start was, hey, I've worked in rural health before. Maybe that would be a good setting because there's a lot of needs out there, but I practically can't be flying around the country to all these little small communities. It just doesn't work due to my life situation. At that time, I can't do it. So maybe this virtual technology is a way to do that. Then it was how would the payment work? What kind of, how would we put this together in a way that would be sustainable for these small communities? How do we use the virtual technology? So a lot of it was just, framing out how the service model would work, and then making the assumption incorrectly that the technology was there to support that. So then we went out, so at that point, I actually just went and talked to, I had friends that worked in some rural areas, talked to some communities. They were very interested in a service of the type that we were offering because the need was real. But then it was, and this kind of gets to the formulation of the product. So initially it was, there's these Polycom systems, right? They cost $150,000, right? And they're fixed in one place, they can't move, and they don't work some of the time, and we have all these different issues. So basically, unless we get a grant from the federal government, we can't really do telemedicine, even though we'd be interested in it. So the first and obvious question was, well, wait a minute, I can this time, it's like we could FaceTime on an iPad. Why can't we just use that, right? So the initial iteration was very service focused, and the technology was all third-party tech that we just cobbled together into a form that worked and cost about, at that time, 1/60th of the so-called market leader to put together, but had better technical specifications. I mean, ironically enough, right? It was just cobbling together third-party products. We were able to accomplish that. I'll never forget the day we put together our kind of hardware and software platform. We sent off to the leading telemedicine equipment makers for their specifications for their top of the line product. The point was to find out how much worse what we had put together was than their product. So you can imagine our surprise when we found out that their $60,000 product actually was worse. It had worse battery, worse screen, worse software, worse microphone. It was weaker computer, and it was $60,000, right? And our thing that we threw together was $1,300. I mean, this was just the reality of it. So we started off with that and just said, wow, I mean, we can just put this technology everywhere, and it solves this problem. And then the problem was then as we began to do more and more work clinically, we ran into things that the third-party telemedicine software at that time also would not do. And so our first step then was to go to the software vendor and say, can you please add this feature because we need this for the type of work we're doing. And the response, of course, was that, you're not big enough and we've never heard of you before, so we don't care. It's not on our development roadmap. get lost. And our problem was that our patients needed it, right? So then we said, well, fine, we'll just figure out how to make software. And that led to kind of version 1 of what we use now, which was obviously a much more involved process than we ever thought it was going to be. But yeah, so that, was it a formal process? I mean, it was in the sense that at each step, we'd sit down and kind of think about what are the needs and try to, game plan everything out. But at the same time, a lot of it was just sort of rolling from one problem to solve to another problem to solve to another problem to solve. The key to it, I think, at least from our perspective, was that the whole time from the beginning, we were not a product sort of seeking, we were not a service seeking a buyer. We were trying to actively solve an existing, well-established problem, and then we were trying to bring what tools we could bring to bear on that problem. And as we did that, we branched off into all these different directions because we had to pull in things to try to solve a known problem.
Right.
Yeah, and if
Let
I
me
would
continue
add
with
to
you.
that, if I would add
Yeah,
to
go
that
ahead,
real
please.
quick,
Yeah.
I think he hit it right on. Elijah hit it right on the head. Is that a lot of the organizations, they look at this as a technology play. It's not. It is a, we're trying to solve a problem. Is technology involved? Sure. Is this going to be a discussion with the C-level CIO? No. This is a clinician, patient problem platform discussion. It is a business and it is a solution issue around healthcare. It is not a technology solution. Yes, technology is involved, but it's really solving that care engagement problem.
Perfect. Yes. Right. All right. Well, so let me continue with you, Dean, then. Like, how did you further go ahead with the product? You have to choose between what things to take up first. Also, like, which is the market segment that you want to target, whether it is some kind of specialty or whether it is going to be more generic, whether it is going to be for lay people, whether it is geographically kind of challenging, different parts of the world or different parts of the country. So can you throw some light on that, please, Dean?
You bet. Yeah. Well, first of all, we had to first look at definitely the market and where it was, failing, not only in the, from the providers, EMR systems and, just from the healthcare engagement, but where was that, extended engagement, have its gaps. So we started looking at that, and then we started looking across what care segments of those models were important. Was it going to be around chronic care? Was it going to be around, different, just general medicine? Where were the actual key determinants around, if I'm going to be an ER physician and I'm transitioning somebody out of care and they're going to go back to their GP, and their GP needs to follow up with them and keep an extended engagement with them. What kind of model was that? What kind of, care was that really focused around? Was it cardiology? Was it, neurology? Was it, whatever? So we really kind of started looking at, where those identifiers were initially. Don't get me wrong, there you could probably try the telehealth RPM across so many segments, but it's really, where's the value? So if I'm, we really focused on the chronic care, diabetes, COPD, the top 3 key issues around social determinants on the major scale. Then we got into, the specific markets around cardiology. And it was also driven by the types of clinical solutions that we could actually bring beyond telehealth, that we could also connect around the remote patient monitoring. What would give the additional information to the provider? So that was kind of the criteria that we used to kind of look at that information. And we kind of built out a grid that kind of said, this is where the key areas that we need to play in, where those basic, factors, derive from, where the influences were, and then how the value of that was going to actually show itself, not only from a reimbursement and things like, that the organizations wanted to achieve, but also around their care improvements, reaching those patients and improving that extended care. Because when you look at rural FQHC, rural markets, I'm not talking about big city, health markets. There are a lot of challenges. I mean, I talked with a hospital group that was sending a bus out 90 miles in different directions to work with cardiac patients to get a checkup, that they sometimes were able to see the patient, sometimes the patient was able to get there, instead of looking at, hey, why don't we put you on a platform that involved, I can engage with you in these many appointments a week or a month. I can also monitor based on, the type of condition that you have. And then I can also have alerts around if a change of condition occurs. So those were our factors, looking at the requirements, the key market drivers, and where we were going to add value. And then from a platform, we were able to extend our technology in those focused areas to ensure that we achieved what we were trying to.
Got it. Elisha, how was it for you? What were the parts of the market? So you mentioned rural, and then you were not necessarily thinking of only internal medicine. It kind of evolved. So what were the considerations? Which parts of the market were underserved, and how did you aim to serve them?
Yeah, I think the parts that were just from medical practice, we had a decent idea of what places were already struggling to find service. That wasn't too difficult for us to identify. I would say the issue with us was when we started, the types of things we were doing clinically were not commonly being done. The reason they weren't commonly being done, one was technology had only recently evolved to the point that you could do that in a flexible and more cost-effective manner. The other was because in the US, at least healthcare only, whatever the insurance companies say is what happens, and nothing else happens until they say it can. Most people will not lift a finger if the insurance company doesn't approve it. So because insurance would not pay for telemedicine in most cases, most people were just doing nothing. They were just leaving things the way they were, and the patients were just allowed to suffer because the system said so. So we bypassed that to a large degree and just went out and built for what we needed. So we looked at it from the perspective of, okay, I'm trying to deliver medical care to someone's grandma in a small town. They don't have a lot of staff. They don't have a lot of technology. They don't have a lot of money, and in many cases are not that technologically savvy. So we need to build for low cost. We need to build for low bandwidth. We need to build for high flexibility. That was kind of the approach that we took. So we were not thinking about things from the perspective of what's the Cadillac of software that you could put together and you require high bandwidth, and if everybody had an HD screen, we weren't thinking about it from that side. We were thinking about it from, okay, if this is if we have 2G, can we still get a video? Can we get a video at all, right? If the nurse doesn't have an email account, is this something that the nurse could figure out how to use, right? And those challenges for us still continue. Absolutely. We still work with those things in mind. But that was a lot of the criteria for us. So we essentially came from the start in the sort of worst case scenario. And then if we can build up from there to something that is more robust but is able to handle those situations, that for us was sort of the ideal situation. So in every case, it was really looking at, again, where's the problem? What is the problem we're trying to solve? What would we need to solve that or to address that effectively in that context, and then kind of going from there. So not building until some study went into what was necessary. And then part of it is just the adaptation, right? You get into it, you start doing it, you learn things you didn't even know before you started, and then you adapt further.
What was the state-by-state legislative landscape? Was there a difference? I'm sure there is.
Yeah,
but,
there were differences, but it was terrible. So Medicare started paying for it allegedly in 2014. But if you called them, they didn't know what telemedicine was when you called the actual billing entity, and they had no codes that you could read until late 2014. So it's like, well, it's paid for, except it's a secret to even your own organization. And Medicaid was very similar, and there were lots of restrictions. So Medicare restricted who could deliver the service, where they could deliver the service, all these kinds of things. The entertaining part, and this is what really got us in the early days, was that the private insurers all claimed to cover. These are the Blue Crosses and United Healthcares of the world. They claimed to cover it, and they published, if you meet these guidelines, we will reimburse you, right? But the trick was they didn't actually want to pay for it. because they were afraid. They were afraid that if you enabled virtual care, then people will start overusing it and they'll get too many charges, right? So what they did instead to restrict it was if you went to them and said, I want to do telemedicine, they just wouldn't allow you on their panel of physicians at all. And they made up all kinds of, oh, it was great. The number of conversations we had that were absolutely surreal. Well, doc, what you do is telemedicine. We pay for telehealth. We don't pay for telemedicine. Right. Okay. So, what's the difference? Well, we consider what you do to be telemedicine and we pay for telehealth. Right. So what is the difference? Well, it's not telehealth. See, we pay for right. What is telehealth? That's a real conversation, right?
Wow.
And they listed requirements. We would meet all the requirements. Then they would create new requirements that they just found under a mattress somewhere, and suddenly decided they had additional things that you needed to meet. So it was this process of just trying to push through, and it was not, I will add, a common concept was that, if you just show the value, right? If you bring evidence or you demonstrate the real use case and how this could be valuable or save money or improve patient care, none of that was true. None of that was true at all, actually. We did all of those things and it did not matter in the slightest. The only reason the situation in our state changed, finally, was we actually had to go lobby the state legislature to pass a law to mandate payment. And it was not until that finally, and that was a fight, that was a multi-year fight. When that finally happened, all of a sudden, all this other stuff changed. This was pre-COVID. Now, obviously, since COVID has hit, now everybody loves telemedicine and they're all about it and they've always been about it and they support it, et cetera, right? And so it's been funny watching that environment change. But for the most part, payers in most US states were not at all cooperative with this, with a few notable exceptions. And we're very much set against letting it propagate and spread because of their worry about so-called increased utilization. And that process now is smoothing out and getting better as we go along, but still there are issues. So a common one we see is that payers will, many states pass something called payer parity laws, meaning they have to pay the same amount. We felt this was the wrong target. They have to pay the same amount for the service virtually as they would pay if it was provided in person. The way the insurance companies got around that was by saying, well, then we just won't work with anybody that wants to deliver the service virtually. So that's why we learned from that trick, because we ran into that in some other states. They just wouldn't credential you. So we changed it to say, if you pay for it, basically, instead of payment parity, it was coverage parity. If you pay for it in person, you are required to pay for it virtually as well. And you cannot exclude a provider just because they want to deliver the service virtually. That still leaves some wiggle room in terms of, they can pay a lower amount of money and things along those lines to try to restrict the utilization, but at least now they have to cover it. And our intention from the beginning was, we have people that are literally dying over these issues. We need to be able to serve them.
That's right.
We need you to get out of our way. That was our way of getting them out of our way. And that actually was effective, at least in our area.
Dean, what was your experience in that? And specifically, you are trying to go multi-country, if I understand right. So...
Yeah, we are global. Mm-hmm. Yeah, we have different, issues on the global scale, especially in certain countries on, the challenges around, just access, but also the adoption there, how they can, actually achieve, value, but more importantly, how it's paid for, because there are some definitely fixed market reimbursements from either the federal governments or the governments and how they're modeled, and organizations like the NHS and what they actually provide and how they set up their structures and how they look at what is long-term care, what is extended care. I mean, all kinds of things. So we definitely have our challenges globally in that area. But on the US side, definitely it's always the value discussion, not with the providers, not with the physicians. There are things that the physicians need in regards to workflow, regards to the proper alerting. You don't want alert fatigue. How do you get a patient notified? So there's a lot of discussions around those from a roadmap criteria and how you address that from a platform. But then, you get into the level discussion on, hey, is insurance going to pay for this? Are we going to get reimbursed for this? If I'm paying X amount for this, what's my ROI? So I run into a lot more of the discussion on the ROI than I do on patient outcomes first. And I try to refocus that as to, well, if you're doing some of these things manually already today, you're asking patients to write things down, come in and, see, why don't you actually extend that care, engage with them, have a way to monitor that information, and then also get reimbursed for that altogether? Because guess what? It's going to improve that outreach to that patient. The patient's going to be more involved in their care, and you're going to actually have a evidence-based solution that you're going to be able to not only train and extend care with your own physician group, your nurses, your nurse practitioners, your MAs, but then you're also going to have a solution, or as an organization, that's going to be able to be a trusted, engaged provider with those patients. So you're going to give a even more avenue for the patient to be involved in their care. But we definitely, there are those definitely, as Elijah mentioned, fighting with the insurance groups, getting, actually what is care, what is a code that really, I heard the same discussion about telemedicine, telehealth, I'm like, okay, well, can you tell me the difference between e-health and m-health? Mobile health, electronic health. So you get into these nuances, and it's just a way, because adoption is very difficult. Healthcare, it's hard to change. And that is one of I could go to a bank today and I could get every information, engagement, automation, things hooked up. I can do anything transactionally. But with healthcare, it seems like there's a roadblock here, a roadblock there, and a roadblock here. And we are constantly having to, get over those hurdles, but also be the ones as the advocate to the groups to get that done. So.
Right. So Dean, you talked about all these challenges, but and of course the parsing by all these biggies, insurance biggies and all that. But were there any anticipated challenges that you kind of you knew about and you were able to prepare for it start?
Oh yeah. Yeah, especially anything related to integration, anything related back to that engagement and how that's going to be integrated either back to the EMR, whether it's observation data from a device or we knew from the challenges around just healthcare and how healthcare is as an entity. There are a lot of challenges on interoperability, integration, security, all of those things. We anticipated those things, connectivity, the challenges around those things. So we actually, did a very good job of anticipating and understanding those. I think, even with access to tools on iPhones, iPads, virtual, solution type engagements, we anticipated that there would be challenges around those, adoption around those. The elderly, the first time you send them an iPhone, how are you going to, make those connections, or sitting in front of, your computer and doing a virtual. You should have seen the original, some of the virtual, engagements. People were moving in and out of the camera that they felt that they had to move instead of just, being there. So there are a lot of anticipated challenges from that standpoint.
Elisha, same question to you. But maybe in a slightly different form. So you yourself were a physician, and one of the challenges that the audience indicated was about the fact that everything should be smooth in terms of the physician's daily workflow. So did you anticipate that different physicians and providers will work differently, and was that like a consideration?
Yes, from the very basics of it, in terms of what type of exam or things like that is done, for most physicians, it falls within there's a broad window, but it's not really that different from one specialty to the other. Those things really were quite similar. I would say in terms of fitting into physician workflow, the challenge is that here again, I think it's different depending on maybe what country you're in and what the healthcare system dictates. The US is very fragmented, with a high degree of fragmentation of electronic records and things along these lines, right? So many different practices have many different EMRs. That's their main practice tool. Figuring out sort of how to integrate into that smoothly is challenging. And I would add to that the fact that the electronic records themselves, because generally they're so poorly designed from a user experience standpoint, they make it even harder than otherwise need to be to integrate any kind of new experience or technology into what they do. Now, some of them, of course, have built video calling into their platforms and things like that, but they're still just generally
it's very proprietary, very kind of like close to
very much, yeah. And it's one proprietary with quality would be one thing, but I mean, you know, without exaggeration, I mean, some of the products that are currently in use in the United States are they're unjustifiably bad in terms of the bill. I mean, just you said, did anyone test this? Did any clinician ever use it? Right? So these are just real difficulties that are there. I'd say the other, you know, as far as challenges. Here again, I mean, I imagine every country has their bureaucracy. The US system is very bound by regulation. And the biggest problem is not that there are regulations per se, it's that they're very inflexible and difficult to move, even when the environment that they were designed to regulate has substantially changed. So some of the regulations that still apply to telemedicine literally were written 15 plus years ago. You know, and you can go to those bodies and say, look, you know, what you thought you were regulating is completely different. The technology is different, patient preferences are different, providers are different, everything has changed. Can we change this? And it's very, very difficult to get change done in a timely manner. And many of the changes, as usual, are being written by third parties. So it's not anyone that's ever worked in healthcare in their life. It's a former attorney that has become a congressperson who now has made this their champion issue, but they don't actually know anything about it because they've never done it a day in their life. You know what I mean? It's this process that makes it at times very, very challenging. So there are areas that are still held back and stifled, at least in the United States, simply because we can't get the regulatory bodies to move in a timely manner.
Let me move ahead, Elisha. So, you know, there would have been like a minimum viable product or like a version 1.
Yep.
So did the version 1 change significantly? Was it like some events that took place, or did you like kind of like, yeah, the plan that you had initially kind of like worked?
I would say the broad plan was correct. Some of the details changed along the way. That's probably how I would describe it. So the basics for an MVP, I mean, for us, it was the simple matter. We need to be able to communicate. We need to be able to do it securely. You know, we need to work in low bandwidth, and we need to be able to do an exam on our patients that would match the exam we do if they were sitting in front of us. That part was there. How we got there changed because some of the technology in the back end, right, were things that you had to bow to what was possible at the time, you know, or build something new.
How about you, Dean? Like, how was that process? Like, you know, so you had the initial roadmap, you had the initial thought, then what happened?
Well, I think we, you know, since we kind of really designed this from a purpose-built standpoint on the, you know, on the back end on outcome and engagement with the patient, we definitely made changes. We definitely made enhancements, but the core from the MVP all the way till now, a lot of the same core structures there, just like Elijah said. We definitely built in flexibility with the, you know, with the advent of the smart technology on the phones and the devices, Bluetooth enablement, especially around the remote monitoring, different connection types, engagements, you know, all the new platforms and broadbands and, you know, different things. So I think our core was very well structured. Yes, there were some adaptions and some flexibilities, but I think we did a really good job from the initial, you know, MVP in 2016 to now. Now, from, you know, some of the advance in technologies and new things, you know, we planned for, we just didn't realize how quickly, I think sometimes they would be in demand and move, but we were able to adapt to that.
All right. And specifically, Dean, about devices. So I'm going to go to the connected systems. So, you know, you had like a major choice about how many devices, different types of devices to you know, to connect and support. So how was that? Like, what was that thought process?
I think the challenges, you know, weren't so much on the clinical devices. I mean, we have you know, remote heart patches. We have clinical devices. A lot of those are pretty standard based on the requirements just by governmental standards and CE and FDA approval, that they have to have certain capabilities around that to enhance the connectivity and to actually monitor what it's supposed to. So connecting to those, the SDK, the APIs, as long as, they're, properly, documented stuff, those weren't really the challenge. The challenge were the smartwatches, the Fitbits, those kind of things, on actually being able to capture that data, Apple Watches, Samsung, and being able to not only capture that, but then the device types, the Bluetooth enablement, the Wi-Fi, how they would actually generate for continuous real time as opposed to planned, connectivities and things like that. So I would say that the challenge was more around the actual advent of the newer smartwatches technologies. And then what happens also in the device world is people get confused around what is, I bought this device, I have it on my phone, gosh, I'm able to connect, I'm able to see that. That is outstanding for a patient. But that's not true remote monitoring in the sense that how is that physician engaged? How is that physician connected? And that's where we came from our platform, because we're device agnostic. We don't care what device you have, what type. Could be a smartwatch, could be a weight scale that's Bluetooth enabled. It could be this, it could be that, or it could be a 1920, scale that you're standing on, and you're going to enter the data manually, and we're going to know that that's a manual entry. Whatever it is, we're device agnostic. Because we wanted to be able to take all of those indicators on that patient and bring that together. So that interoperability back either to our portal, to the physician portal or the platform, or even integrated back to the EMR for that physician view on the clinical chart. We wanted to be able to take that approach, so we weren't bound specifically into niche players. So that was our approach.
All right, Bhagyashree, do you have any questions from the attendees? I know I asked a lot of questions, and this was just wonderful for me. But can Elisha answer a question that is of particular interest?
It was wonderful discussion, Prashant. So far, we haven't have any questions. Audience, feel free to chat us your questions, and then we would be happy to take those.
Yeah, and we can take these questions even after the session, right? So, every question is important, so we'll make sure that it is answered, and we'll respond to you. So, thank you, Elisha, and thank you, Dean. And Bhagyashree, over to you.
Thank you, Prashant, and to our panelists for this wonderful discussion. And I'm sure we all are going back with some food for thoughts today. I would like to thank our viewers for joining this session through Zoom and as well as via LinkedIn. And you have been an amazing audience. Thank you so much. In the meanwhile, if anyone from the audience would have more questions or would like to reach out to our panelists, feel free to drop a line at hsinfo@harbingergroup.com. Thank you once again. Take care and have a great one.
You bet. Yes. Thanks, everyone.
Thank you.
Thanks, Elijah.
Thank you so much. This was wonderful.
All right. Bye.
Bye.
Bye.